with acute kidney injury because there was a less amount of urine output, and sepsis induced kidney injury, which is SAKI, which is very important, and this SAKI is a very common complications which occurs in patients with severe sepsis with a significant acute and a long term implications. SAKI is defined by the simultaneous presence of severe sepsis along with acute kidney injury, and the definitions of both syndromes have evolved significantly over the past decade. The recent sepsis 3 definition requires and says that a dysregulated host response to infection with a life-threatening organ dysfunction measured using the sequential SOFA score, and the definition of acute kidney injury again varies, but the commonly used ones are the improving global outcomes, which is the KIDCO definition of acute kidney injury, which is dependent on the traditional but insensitive markers of renal function, that is the urine output and the creatinine values. Now, sepsis is one of the most important complications of any infections. Acute kidney injury is one of the subcomplications in these patients, and sepsis accounts for increased production, and there is more amount of acute kidney injury. The estimates of incidence of acute kidney injury as a complication of severe sepsis have been varied, and they have been varies from person to person. The cohort studies into intensive care patients with severe sepsis often reported to as incidence of renal replacement therapy requirements between 28 to 28, and the discordance is reported between the incidence of possibly driven by various definitions of both severe acute kidney injury and sepsis, which both have been revised a number of times in the past decade. So, the most important criteria for acute kidney injury is the Reifels criteria, the KIDCO criteria, and the Atkins criteria. As per the Atkins criteria, there is an increase in the serum creatinine values of more than 3 milligrams per deciliter or more than 50% within the 48 hours, and there is a decrease in the urine output of less than 0.5 ml per kg body weight for the more than 6 hours. And the KIDCO, there is again an increase in the serum creatinine values of more than 3 milligrams per deciliter within the last 48 hours and more than 50% within 7 days, and the urine output of less than 0.5 ml per kg per hour for more than 6 hours. Now, the staging criteria for definition of these acute kidney injury, there was a Reifel 1 or the stage 1. In the Reifel 1, there is increase in the creatinine to 1.5 times the baseline value, or the urine output of less than 0.5 ml per kg body weight for 6 to 12 hours. And as per as this, again there is an increase in the creatinine value of 0.3 or milligram per deciliter, or 150 to 200 times above the baseline values. And the KIDCO 3, there is increase in the serum creatinine, or there is increase from 1.5 to 2 times the baseline values. And the Reifel 2, there is increase in the creatinine to 2 times the baseline value, or the urine output is less than 0.5 ml per milligram per kg body weight for more than 12 to 24 hours. And in the Atkins form, there is an increase in the serum creatinine value of 200 to 300 times than the baseline values. And the KIDCO ones, the increase in the creatinine values of 2 times to 3 times than that of the baseline values, and the urine output is less than 0.5 ml per kg body weight per hour for more than 24 hours. And the Reifel 3, again, there is again the increase in the creatinine times to 3 times the baseline, or the Atkins form, there is more than 300% times increase in the baseline, or there is more than 2 to 3 times than on the baseline. And there is again these criteria or the Reifels criteria, KIDCO criteria for diagnosis, and the pathophysiology, which is more important, how you should optimize it, when you should smell it, how you should treat it. There is an altered blood flow because there is again severe sepsis and septic shock. There is a low perfuse state. There is a shunting of the blood which occurs from the medulla to the renal cortex, and this is again consistent with evidence of microvascular changes which are seen in or the organ beds in patients of severe sepsis, which has been extensively investigated. The potential mechanisms for contributing these microcirculatory derangements include the glucocalyx and the endothelial dysfunctions which occurs in patients of severe sepsis and septic shock in response to the various toxic metabolites and the mediators of inflammation which are being liberated because of severe sepsis. And there is also reduced GFR filtration pressure because of a greater dilatation of the efferent arterioles as compared to the afferent arterioles because of the altered physiology. The limited toxicity and the tissue damage. Now, the microvascular shunting can also result in a hypoperfused state. There is also tissue hypoxia which occurs at the medulla, and when the oxygen delivery is again often uncoupled, there is also again alterations in the microvascular blood flow, which can again lead to a transient shift of these prolonged inflammatory markers and these mediators through the vessels, which again impair the flow, and they also produce a kidney injury. And this prolonged exposure, which is associated with increased vascular permeability of the glucocalyx and the endothelial dysfunction, as well as the various activation of the cellular metabolic responses, all have been described, and these ultimately they cause the impairment of the microcirculatory autoregulation, and therefore there is a kidney injury which occurs. And at the same time, there is a cellular reprogramming which is there, and there is a dissociation of the structural as well as the functional change because of the all above factors, which again cause impairment of the kidney functions because of kidney damage, because of the direct amount of affection of the kidneys.